Medurstand, Understanding Medicine.
I'm Professor Aziz Rehman, and today we're going to talk about a very important aspect of diabetes management, that is medical nutritional therapy for diabetes. I'll be basically focusing on type 2 diabetes, but of course most of the principles will be applicable to type 1 also. Diabetes has got many components, but the main component is hyperglycemia, and most of the therapies they actually focus on hyperglycemia. Although now we consider diabetes as a very complex disorder, we focus on cholesterol and blood pressure and other things. But this lecture will be basically medical nutrition therapy to control glycemia or to prevent hyperglycemia, whereas to make sure that all other nutrients which are essential, they are provided. So patient may be just the start of the treatment, only after the diagnosis, or patient may be already on medication or insulin. This therapy remains important. So I think before I discuss different components, I'll talk about few statements. So these are basically summary points. So this is a slightly different style of presentation. I'm going to present the summary points first, and then I'm going to elaborate on them later. The first statement is that medical nutritional therapy is the cornerstone of treatment of diabetes. Extremely important. It is just not possible to control diabetes satisfactorily without controlling diet. And this medical nutritional therapy should be started immediately at the time of diagnosis of diabetes mellitus, or even pre-diabetes. Somebody went for the test fall in the range of pre-diabetes. Still, I think same diet should be started. And I would recommend that those patients who are prone to develop diabetes, even if their glucose values are still within normal limits, they should actually adopt this lifestyle, because sooner or later they are going to develop diabetes and going to accept this diet. Those with family history of diabetes, those with truncal obesity, which is extremely common. Apparently slim looking person may actually have truncal obesity when you measure their waist. And there is history of gestational diabetes. Their present glycemic control may be normal, but they had suffered from GDM, so they should also adopt this medical nutrition therapy meant for diabetes. People with non-alcoholic fatty liver disease or metabolic associated fatty liver disease, or people with hyperlipidemia, especially with hypertriglyceridemia. All these conditions are predisposing factor for diabetes. So even if glucose values are within the normal range, still I think these people should be encouraged to adopt this dietary pattern. Another statement is, no plan is good enough unless it is doable. Now, of course, we always try to make ideal plans, but ideal plans are often not doable. There may be limitations on the availability of certain foods, there may be limitation on the affordability and the limitation of patients' preferences. So I think make a plan which is doable. Of course, closest to the ideal, but which is doable. And then carbohydrates are not toxic foods. So after the diagnosis of diabetes, many patients, they immediately stop taking sweet carbohydrates. So I think they need to be explained that they are not toxic drugs. Only too much of them, if consumed in large quantity, they have harmful effect if you are diabetic particularly, because they lead to surges in glucose, and surges in glucose is linked with cardiovascular events, and they could cause weight gain, because when we overeat, mostly we overeat carbohydrates, They can promote to truncal obesity and NAFLD, insulin resistance, and hypertriglyceridemia. All these are the condition which can predispose to diabetes. So carbohydrates can be consumed even if you're diabetic, but they should be consumed in lesser quantities and in complex carbohydrate form. So I'll elaborate on these points later. No meal sounds like a meal without carbohydrates. This may be my personal preference, but I think all meals, whether this is Asian cuisine or European or Western or American, all meals, they have some portion of carbohydrate. In fact, predominant portion of the meal is carbohydrate. Typically 60 to 70% of the carbohydrates, the calories, they come from the carbohydrates. In our country, we take roti in different forms or naan. Rice is also consumed in all societies. Potatoes and pastas, they are all carbohydrates. So carbohydrates should be included in all meals, because without that, meal doesn't sound complete. And then we should also, try to restrict them as much as possible, restrict their quantity. Another point is that individuals with diabetes have the same right to enjoy food as those without diabetes, because it is a chronic disease and they have to live their lives. So I think they have the right to enjoy all those foods they used to and which we do. So I think this principle is also very, very important. Empowering the patient with education is extremely important. Without that, we cannot expect that your diet plan will be actually followed, because patient need to understand. They should be empowered with the knowledge to make some adjustment in their meal plan. And in the management of any chronic disease, may it be diabetes or hypertension or some other disease, I think quality of life should never lose the focus. So we should make a diet plan which is compatible with good quality of life. Now, those found to have their blood glucose level above a certain figure, like for example fasting sugar above 126 and HbA1c above 6.5 or above, and similarly postprandial sugar of 200 or above, these individuals should be described as individuals with diabetes rather than calling them diabetic patient. Now this has got some psychological implications, because they are hardly patient because they don't have any symptoms. So they should be respected, and if you call them individuals with diabetes, then I think your advice will be taken by them and followed. The more chances, and there will be less psychological setback also, and there will be no taboo also. So these were the points, and now I'm going to show you different components of medical nutritional therapy in diabetes, and then we will discuss them in detail. First of all, I think the principle is to cut down on calories. So total caloric intake should be reduced. Why is it? Why so? Because most type 2 diabetic patients are overweight. And the second rule is to cut down on carbohydrates, because carbohydrates actually constitute the main component of our diet, and carbohydrates are responsible for hyperglycemia, and carbohydrates are responsible for many other problems like fatty liver and hypertriglyceridemia. And at the same time, we must ensure that they take sufficient amount of good quality protein, which could be animal source protein or vegetable source protein, but they must take enough protein to maintain their muscle mass and also to have essential amino acids. Then essential fatty acids. Fats have some saturated, unsaturated fats or polyunsaturated fats. They have some fatty acids which our body cannot make, and they are essential for our metabolism. So a certain amount of calories must come from oils or unsaturated fatty acids. Then fiber and water. Our traditional diet has been very rich in fiber, but modern diet has got much less fiber. So we make sure that patient takes a food which has got sufficient fiber and water, because they have their own benefits, which I'm going to discuss later. Micronutrients. Whenever you are following a certain diet plan, there is a risk that you might develop deficiency of some micronutrient. In diabetics, it's particularly true because some of the drugs, they can actually cause deficiency of some vitamins. So I think we must make sure that their diet has certain amount of micronutrients, or they are supplied as a supplement. Then sweet tooth. I think we eat food for two reasons. One is the biological need, because we can't survive without food. But another reason is hedonic eating. That means we eat for pleasure. So even diabetic patients should be allowed to have some food which gives them pleasure, just for the sake of pleasure. So now I think let's talk in detail and cut down on calories. Daily requirements of healthy adults is in men 2000 to 3000 depending upon your level of physical activity. Those who have sedentary lifestyle, their requirement is close to 2000, and those who have active physical life, their requirement will be 3000. Similarly, in women, the requirement may be 1600 to 2400. So diet plan should be made in a way that they need sufficient calories to maintain their weight if they're normal weight, and the chart should have lesser calories, like 1500 calorie or 1000 calorie chart should be constructed, and less than 1000 calorie chart is actually not workable on long term. And I think it is the reality that most of us, if not all, overeat. So these patients, they should be encouraged. When you tell them not to overeat, their first response would be that they don't actually overeat at all. But when you sensitize them, then they will realize that there are many things they could avoid. So I think we should not overeat. And modern diet is very, very energy dense with very little fiber. One quality of fiber is that it doesn't have calories, because our normal gut enzyme, they cannot digest cellulose, which is the main fiber in our diet. So modern diet like pizzas, sandwiches, burgers, these are very rich in calories. They do not have fiber. So that is why volume wise they may be consuming just the right amount, but calorie wise it is excess. And 80% of type 2 diabetes patients, they are overweight. Maybe 5%, 10%, 20%, but they are overweight. Some may be obese, some may be grossly obese, but 80% are overweight. So in almost all, or at least in 80%, diet should be restricted in calories by 5 to 10%. Based on their current weight, an individualized diet chart should be constructed. Now, same diet chart may not be suitable for everyone, because people's dietary preferences are different, affordability is different, availability of food is different in different areas. So I think an individualized chart according to that person's weight should be constructed, preferably by a dietitian, and preferably a dietitian who has the knowledge or experience of managing diabetes patient. And along with the diet, this is extremely important, aerobic exercise. Aerobic exercise is the one which one can do for an extended period of time. And recommended duration is 150 minutes per week, with 2 additional sessions of high intensity exercise. A high intensity exercise does not help to reduce weight, but it will help to maintain your muscle mass and improve your body structure. So one aerobic exercise basically to help lose some calories and to open up vessels, but this high intensity exercise to maintain their muscle mass. So idea is that by restricting their calories, you bring their body matrix in the normal range. And these are the body metrics. One is ideal body weight, which is very rare to find. These are the formulae, and these are basically based on the life expectancy. This data is taken from the insurance companies. These are the weights, and the people are likely to have maximum life expectancy without developing disease. So I think this is perhaps not applicable. Body mass index, which is body weight in kilogram divided by surface area in meter square, and this is derived from the height. So this is the range in Western world. 18.5 to 24.9 is normal, whereas in Asian it is 18 to 23. So 25 would be high for us. So this is actually we can predict disease predisposition based on BMI. But BMI has got a lot of limitation. For example, a very muscular person who does not have excess fat, his BMI will be high, but he is not at risk of developing these diseases. I think one best criteria to measure their weight is waist circumference. And it is measured at navel level with a measuring tape when patient is standing and with relaxed posture. In men, ideally it should be less than 37, and in women it should be less than 31.5 ideally. And this yellow is borderline high and red is of course high. So most diabetic patients are likely to have their waist circumference in red or yellow range, but I think we need to bring them into green range with chronic caloric restriction and exercise. So we're done with the first agenda item, and let's now take up the second one, cutting down on carbs specifically. So this was cutting down on all foods, and this is cutting down on carbs. Particularly those which have high glycemic index. Carbs are different than other foods because of their ability to increase glucose level. Those foods which have more chances of increasing your glucose level are the ones which have high glycemic index, and this concept I'll explain in more detail in the next slide. So carb contents in normal diet, they are like 50 to 65% in Western diet, and in Pakistani food I think it is 70 to 80%. And within the country it also relates to the level of their affordability, because carbohydrates are relatively cheaper foods, so poor people are likely to consume 80% or even more of carbohydrates. So we need to restrict carbohydrates, particularly if the consumption is more than recommended. I think we should try to bring it down to 50 to 60%. Now please note down, even after carb restriction, their total food contents would still be predominantly carbohydrates, containing about 50 to 60% calories. And we need to cut down on carbs because they cause surge in glucose. And I already mentioned that surge in glucose following a meal is related with cardiovascular complication. Now this is the concept of glycemic index. It does not measure the total amount of carbohydrate in any particular food. So when we measure glycemic index, we take a reference food which is usually glucose dissolved in water and total carbohydrate 50 gram, and we give that to volunteers and we draw this curve. So of course, even in healthy people, after consuming this large amount of carbohydrate, glucose level will rise very rapidly and then come down despite insulin response. And then we measure it with the food, and whatever food we measure it with, like maybe a burger or some food, and it has the same amount of carbohydrate 50 grams, and patient consumes it, and then we serially measure the glucose and make a diagram, make a graph, and we measure area under curve of reference food and area under curve of the test food. So then we calculate the glycemic index. A reference food, which is glucose, and a test food, which could be any food, mixed food, containing same amount of carbohydrate, which is usually 50 gram is given. Blood glucose is monitored for 2 hours, and area under curve of test food is divided by area under curve of the reference food. This is the test food and this is the reference food. Reference food being glucose, it does not require any digestion. It is immediately absorbed. So of course it will cause this kind of glycemic curve. So if this ratio of area under curve of test food divided by area under curve of reference food is less than 50, that food will be classified as low glycemic index carbohydrate or food. So those which have more than 70, they are the foods which have high glycemic index. So of course, without saying, it means that those foods which have low glycemic index, they should be consumed in more quantity than those which have high glycemic index. Those which have got high glycemic index, they should be consumed in lesser quantity. Now the concept of glycemic index does not apply to non-carb diet. For example, if you take a steak without any sides, so if you take a big piece of meat, so although it has a very small quantity of carbohydrates, but the concept of glycemic index does not apply there. So it would be applicable only on mixed foods or food which have got some carbohydrates. You know, all carbohydrates are not the same. Some are complex carbohydrates and some are plain carbohydrates. Plain carbohydrates are likely to have high glycemic index. One example is sucrose. Now, sucrose is sweet. It is sugar, but it is not glucose. It is a disaccharide. It has to be digested in the intestine. Only then glucose is released, and only half of the total sugar consumed. So the glycemic index is 65. And compare it with white bread. White bread does not have sweet taste, but its glycemic index is 75, more than sucrose, because in the process of baking, some food is actually converted into glucose. White rice also have very high glycemic index. Breakfast cereals have again very high glycemic index. Boiled or mashed potatoes have got very high glycemic index. Orange juice has got high glycemic index because it has got some glucose in it, some fructose, but some glucose. Coke, which is again, it has got fructose and sucrose, glycemic index of 65. And watermelon, which we eat usually in large quantities because it is considered to be relatively safe thing, but it has got very high glycemic index. Now comparing this with the other one, those with low glycemic index, these are called complex carbohydrates. In this, the carbohydrate is present in the form of disaccharides or polysaccharides, and they have to first digested by our enzyme system, and then glucose will be absorbed. So whole grain wheat roti, brown rice, oatmeal, lentils, fruits, especially grapefruit, avocado, blueberries, strawberries, apple and pears, and green leafy vegetables, non-root vegetables, and whole grains. They have low glycemic index. So patient can consume carbohydrates predominantly from this category and smaller quantity from this category. Okay, so this is why this concept of glycemic index is extremely important. Glucose polymer supplements. There are people who cannot take normal feed. Like for example, post-operative state, patients suffering from stroke, sometimes they cannot take normal food. So for them, these specially formulated meals can be used. They're suitable for those who are unable to consume normal food. Glucerna is one example, and there are many other commercial supplements, and the glycemic index is quite low actually. They have this is a soluble food, but glucose is in the form of polymers, so it is not readily digestible. It first have to be converted into monomers and then it will be absorbed. So it provides calories, it provides carbohydrates, but in the form of polymers. Tube feeding for patients with severe dietary restriction, I think this is very good solution. And I think I like to talk about artificial sweeteners also. They are not carbohydrates, they are either amino acids or some other substances or derived from sugar. And saccharine, for example, aspartame is an amino acid, stevia is a natural sweetening agent, sucralose is derived from sucrose by chlorination. These are generally safe and can be consumed as desired. Their glycemic index is 0. At least from glucose point of view, they are very safe. There are some reservations. At least some people have some reservation about these artificial sweeteners. I don't recommend taking them, but I think they're okay. If you want to take these artificial sweeteners in moderate quantity, I think they are okay. They are not toxic. At least their harmful effects are not yet proven. I'd like to thank you for your very patient listening to this lecture, and this is the link to my channel Medurstand, which features many other such lectures. Thank you very much and see you soon again.